Well, hello, everybody. This is really exciting. Of course, we have two great speakers, and the bar is really high. Good thing that Dr. Schwarzman is after me, otherwise I'll be in trouble. But he's a fantastic speaker too. So I see, few faces that I know of patients here. Oh, let's go. And I'm a medical oncologist. For the rest that don't know me yet, and we treat patients with sarcomas and also TGCTs here at OSU. Disclosures, I've done some consulting for Decipher and for Daiichi in the past. And today, basically, we're going to be focusing in these four drugs that you see listed here. I think those are kind of a more interesting, and basically, we're going to do like a snapshot of what's happening with them currently, and then sharing with you some of the data that is already published. Before we jump in, I wanted to just bring this to your attention. I know you guys know already this, but once in a while, patients ask me this question in my office. They ask me, okay, Dr. Tinoco, what is a clinical trial? And usually I just use the NIH definition. I think that's really a good one. And just basically it's a research study that is testing an intervention. An intervention can be medical or, surgical or behavioral, and you want to test that in people. And you're doing that because that's the way the researchers have to determine if the new treatment is safe and effective. And that's kind of what you're trying to do. So there are four different types of clinical trials in humans. More commonly, we see phase 1 and 3. In phase 1, it's basically you're testing the intervention of the drug on a small group of people, and you determine the early safety, side effects, and what is the right dose. Phase 2, you are testing the same drug or intervention in a larger group, and that will help you to determine preliminary activity. You want to see if there's a signal there. You want to see also safety and short-term side effects. Then you have the phase 3 trial, which you're going to aim to test your intervention in even a larger population. And then you're going to compare that new thing with something that, it can be another medication or it can be placebo. And then you want to see which one is better. And the phase 4 trials, you see them less often. But basically, once you get the approval by the FDA, usually with the phase 3 trial, you're going to see long-term safety and effectiveness with those studies. So now that everybody's in the same place in terms of clinical trials, then going back to Dr. Parker's points, she had an excellent presentation. How do you know? What do you know that a drug works, right? And it's all in the endpoints. So when you design a clinical trial, you want to try to measure specific outcomes that will help you answer those questions. Because the bottom line is you want to know if this is working for people, and that's our clinical trial endpoints. For TGCT, basically you're looking at laboratory measurements, MRI measurements, but also you can look at questionnaires about symptoms, right? You're looking at pain, you're looking at stiffness, function, and at the end you want to see how patient will feel, function, and survive. So now we're going to talk about the drugs. And the first one that we have here is the vimseltinib. This drug was named DCC 3014. And as you guys know, when a pharmaceutical company is developing the drug, usually you code the molecule with a long name, and as you evolve in the development of the drug, getting closer to the commercial phase, then you put a name on it. So that's why they have kind of two names, and that's the reason. So this one is an oral CSF1 receptor inhibitor. There is still a phase 2 trial that open, the cohort B, and that's for patients that were previously on pexidartinib. So that's still accruing. I understand it's still accruing. And then the biggest and the greatest is the phase 3 motion trial, right? And that trial recently completed the accrual. Currently, it's not accepting new patients. And this study was testing basically twice weekly oral pills. That was a placebo randomized 1-to-1 trial for 21 weeks, and that was blinded, meaning that nobody knew really, if they were actually getting the drug or they're getting the placebo. And then it's a standard for most of these trials that when, after 24 weeks, then you kind of open the label, meaning that, you see who on mass data, right? You know which patients are receiving what. And if the patient was not receiving the study drug, then usually you can cross over, and that's what, that means. For you to be part of this trial, patients should not have good cervical options, and they should have symptoms. In this study, previous TKIs, like we were discussing in the previous lecture, like imatinib and lorlatinib were acceptable, but if you were in any CSF1 receptor treatments, you were not able to participate in this trial. And we did participate in this trial here at OSU. So here I'm going to show you a little bit of the phase 2 data. And this one was presented at ESMO in 22 by Dr. Blay and at the colleagues. And you guys are an expert already. I don't have to tell you that this is a waterfall plot, right? And then we have a pointer here, perfect. So here, the left side, as we know, you see the changes in the size of the tumor, right? So if something goes up, means that it's growing. Something goes down, means that it's shrinking. Each individual column is going to be a patient. And in this particular graphic, you also have color coding by the response. And this is the magical threshold of 30% that Dr. Burgess was mentioning before. And that's why you see here the colors. And sorry, I'm colorblind, but grossly, you can see that the bigger the column going down, the stronger the shrinkage, right? And that's kind of what you want to see. So here on the left side, you have cohort A, which is for patients with no previous CSF1 receptor treatments, and the cohort B, that's the one open. And in both, you can see actually that there is a significant response, right? You see shrinkage. In the cohort A, the best objective response was 53%, and in cohort B was 46%. And at week 25, in the cohort A, you saw an overall response of 38%. So that was really, really interesting. The clinical benefit was reported as 100% of all the patients that participated in the trial. Again, this one is a Summers plot, right? And then in each of the columns is a patient, individual, and then the x-axis is the months on the study. So the bigger the number down here, that means that the patient would stay in the drug the longer, right? Here, each column you see closer, I don't know if you can see it very well, you can see little figures, right? Each one has a meaning. So it can be, at the time, the event was measured. So you can see the patients had complete response, partial response, and so on. And then the arrows mean that it's ongoing. So you see a lot of arrows, meaning that at the time that this data was reported, kind of like a snapshot was done, patients were still taking the medication. And that's usually a good thing, right? The longer people stay on the medication, usually is a good thing. In this graphic, what I'm showing you is that in the cohort A, the median treatment, people stayed on this medication for about almost 10 months, and cohort B, about 6 months. And this is a really interesting table too. This is focusing in the side effects. And the toxic profile, you're gonna see that in the studies that are being discussed later on, that swelling, especially peripheral edema, swelling around the eyes, is a common thing that we see. Swelling in the legs is also something that we tend to see. Fatigue is another one. And skin rashes is important and not common. And occasionally you can also have some GI problems. But overall, the drug in the phase 2 study was well tolerated. Okay, now moving on to the pimicotinib, or ABSK021, sorry. So this one is another oral CSF1 receptor inhibitor. And this one will have the phase 3 trial, which is the maneuver, opening here in the coming weeks at OSU. We were selected as one of the sites, yes, lack of sleep. Great. So we did have some data to share with you about the phase 1 trial. But this study, also the phase 3 trial, is going to be a double-blinded, right? People will not know which arm, you're going to be participating in. Can be a placebo, and usually at 24 weeks, 25 weeks, basically 6 months. You stop, see where you're at, and then if you didn't receive the medication, you cross over. And I think that's important for patients. So this is here showing you a little bit of a phase 1 trial. And as Dr. Borges was mentioning earlier, when you're seeing these tables, you want to see that, what are the characteristics of the patients. You want to make sure that it kind of, similar. This particular study is an early trial. And usually what you start is you start a baby dose of the drug, and then you go up for a different dose, and you want to see how, what are side effects and so on. So here we see 25 daily and 50 milligrams daily. And then the characteristics of the patients are really similar, of course. And then here we see a little waterfall plot. And then we see here in the left-hand side, the 25 milligram cohort and then the 50 milligram cohort. And what you can see is a significant response in both cohorts with different doses. So, the key here, what I'm trying to show is that about 68% of patients that participated in this trial in an expansion had shrinkage of the tumors, and about 90% of patients remained on treatment, which is very significant too. And this again, another Summers plot showing you similar characteristics. In terms of side effects, interesting again. So you see some edema, right? That is not surprising. Some swelling around the eyes, some skin rash, and some abnormalities in some of the lab work that you see there. Overall, the medication was well tolerated. So now switching gears just a tiny bit to different groups. So I presented this, I grouped them in a similar way. So what we're going to talk about now is going to be the monoclonal antibodies. So what is a monoclonal antibody? It's basically an engineered protein that is very targeted, and what does is just binds directly to a one substance. So potentially the advantages of monoclonal antibodies is that they're really selective, and ideally, I guess it's going to have less side effects, and that stay in the body for a longer period of time. And that would be an important factor in terms of the dosing of those drugs. Potentially, the disadvantages are that it can trigger an immune response and requires usually an IV injection, and that means that usually the oral version is not available. So one of these drugs in this category is the emactuzumab. This is an intravenous antibody against CSF1 receptor. The phase 3 trial will also be opening here at OSU in the next few months. We were selected as one of the sites, and they will be testing IV infusions every 2 weeks for 5 treatments, and then a 3 months observation. This trial, like the other phase 3 trials that we discussed earlier, is going to be randomized for 24 weeks, and it's going to be blinded, and then after that, it's going to be open label, meaning that patients that were not receiving the medication will be able to cross over. Interestingly, with this drug, patients older than 12 years will be allowed. And I think this is really interesting because there's a big chunk of population between 12 and 18, right, or younger than 18, that really we don't know how these drugs will affect them, and we don't know how to help them, right? And we know that young patients can have also TGCT, and sometimes really we don't know how to help. And I think that would be interesting. Here at OSU, we only see patients 18 and older, but this is tapping a really good question here for this population. For patients to participate in this trial, no surgical options will be available, or they will consider high risk. And prior treatments they're allowed. That means that patients that receive pexidartinib before are okay to participate, but they need a washout period, meaning no treatment for at least 3 months before being part of a trial. So I think this is good. So this is the phase 1 data, and including the data expansion that was published in 2020. And that included 63 patients. And they received IV infusions every 2 weeks for 10 weeks. The median age, putting the 63 patients together, were about 38 years old, in the range, as you can see, 18 to 82. And most of the patients have TCT in the lower limbs. Another waterfall plot, and you see all the responses in most of patients. Is color coded by the dose they use, because it was a trial that tried go up and escalate the dose as much as possible. As you can see, basically most patients have shrinkage of their tumor. Another Summers plot, and then in this case, you can see in the bottom that the largest number there in terms of days is 800 days. So meaning that the response were durable in this trial. 70% were still having response at the first year, and 64% they had the response at 2 years. So that's sustained over time, which is really unique for this drug. 71% of patients that participate in the trial achieve either complete response or partial response. And they have a control rate of disease in 98% of the patients, which is remarkable. In terms of side effects, fatigue, we heard that before in the other drugs too, swelling around the eyes, saw that too, some headache, and overall, the drug was very well tolerated. And now we're switching gears to another drug in the same category, that is an MBX05X. And this one was the joint injection. And here at the OSU, were able to participate. Dr. Schwarzman was a local PI at the trial. They recently updated some of the information in CETAS 2022. But as I understand, we don't have an official paper published yet. There is a phase 2 trial that's going to be kind of a long-term, still in the works. I haven't heard much about it, but I think there's something going on in Australia. So at least, yeah. So I think that's TBD. And then they're going to test injections once every 4 weeks for a number of 6 injections. For people to participate in the trial, no prior CSF1 receptor therapies will be allowed, and patients need to have something to measure. So this is a little bit of the data on the early report of the phase 1 trial, where 11 patients were treated, and 8 patients had some tumor reduction, more than 30%, and then there were improved outcomes in terms of symptoms. Let me just show you the next table. So this is the response rate divided by doses of the drug. So as you can see here on the right-hand side, they were looking at 3 months, 12 weeks. And using the standard RECIST criteria that Dr. Porges mentioned earlier, 38% patients have some response, right? And then modified RECIST, which is, depends on the trial, but sometimes you can tweak it a little bit. They can go up to 50. And then in the lower dose, you see the numbers there. A third of those patients have response. And just bear in mind that this is really, really tiny. Population is only, 11 patients, so it's not a lot, but this is significant. In terms of side effects, the idea is that if, going back to your question about viability, I still remember that one. If you have the drug confined to the joint, so the systemic absorption more likely is going to be lower, right? And the free drug affecting off-target places, potentially is going to be less, right? And then most likely you're going to have less side effects. So that's the idea with injectables, which I think is very important. But the drug was very well tolerated. A little bit of fatigue, joint pain, some rash reported, but the numbers are really small. And that happened during COVID, so there is COVID-19 there too. And with that, I'm gonna share with you kind of like a little table with some of the side effects and the different drugs. I'm gonna ask you to remember that I'm gonna make a quiz. I'm kidding, I'm not. It's just to have an idea. Of course, we can go over things again, but this is exciting, having so many drugs in the pipeline for patients like you. I mean, I'm happy to hear that, and I'm hoping to make more progress as the time goes by. And also, I'm so excited that you guys are here. I feel like, you know, this community continue to grow and we can continue to help each other. We want to be a resource for you to help you in your journey. And, you know, with that, this is my information. You can, you know, email me. There's my Twitter there as well. Oh, sorry, X. And, you know, if you have any questions, let me know. Thank you.
Any questions for Dr. Tinoco? Go ahead, Jenny.
I'm just looking back at all the positions, just thinking about the drug and the drug target. What else is CSF? What is the else is the CSF1 receptor involved in physiologically? Like, because it can't just be in the tumor, right? There are other things that it does regularly in the body. What are we targeting when we take a systemic drug that does that?
Yeah, so I think that that's a great question. So sometimes the challenge is that these targets generated in the cancer also present a normal tissue, right? Or they can be normal in other places. And that's kind of what happens. So it will be easy if the cancer only has a unique target and you just hit it and, you know, the end of it because there's no presence anywhere. But I understand that it's present in the immune system, right? It's also present in organs like the liver and heart and so on. And I don't think I can tell you exactly what's the specific function of it. Maybe we can talk about it in a little bit. But the challenge is that that target is present in other healthy tissue that helps with normal function of your body. So sometimes it's overproduced, like in this disease, and that's why we can target it. But that's a challenge, and that sometimes we have the off-target effect that leads to side effects.
Yeah, Pexi is my favorite example. You see all the white hair in the room? That's an off-target effect, right?
Melanocytes, yeah.
That's the loveliest. Yeah, so there's off-target effects with all sorts of things, but CSF is part of the recruitment of your immune system. It's also part of your gut and biliary health as well. So it's part of any sort of pulling in of immune cells. And you can imagine many functions that you would have that in.
So I went to high school and grad school in Columbus, so I'm always happy to visit, but it's still a little bit of a bump. We have family in Houston, so I'd love to visit, but it's still a bump. Is there such a thing as collaborating with a local physician and participating in a clinical trial?
You know, that's a great question. So I think that especially in science or cancer care and these rare diseases, collaboration is key. So that's why we're so excited to be part of this effort. And usually it's a common community, it's a small community, and we try to help each other very much. So sometimes when we don't have a clinical trial, but I know that maybe Dr. Borges or, you know, Dr. Tapp or any other doctor has it, we'll, you know, give them a call and then set things for them, even in MD Anderson as well or in other places. So as I told before, we want to be a resource for you to guide you through the journey. And even if we don't have, for example, trials ready to go, you know, we can point you in the right direction. We're here to help.